Young male patient of average height and build is lying comfortable on the bed, having a pulse rate of 90 beats per minute. It is of normal rhythm, volume, and character. Blood pressure is 110 by 70 mm of mercury. There is no JVP, cyanosis, clubbing, and pedal edema. On examination of the pericardium, there is a visible impulse at the apical area. There is no scar, bulging, or deformity. The apex bead is displaced in the sixth intercostal space, lateral to the midclavicular line. It is thrusting in character. There are no heaves, but a systolic thrill is present at the apical area. On auscultation, the first heart sound is soft and second heart sound is normal. There is presence of a high-pitched pain systolic murmur at the apical area, which becomes loudest during the expiration and it radiates towards the axilla. The lung fields are clear to auscultation. There are no signs of the pulmonary hypertension. There is no stigmata of the infective endocarditis. The diagnosis is mitral regurgitation. A middle-aged male patient is lying listening on the bed, having a pulse rate of 92 beats per minute. It is irregularly irregular, of normal volume and character. The blood pressure is 110 by 70 mm of mercury. The JVP is raised and pedal edema is present. There is no cyanosis and clubbing. On examination of the pericardium, there is a visible impulse at the apical area. There is no scar, bulging, or deformity. The apex beat is displaced in the sixth intercostal space, lateral to the midclavicular line, and it is thrusting in character. There is also presence of a systolic thrill at the mitral area and a left parasternal heave, and P2 is also palpable in left second intercostal space. On auscultation, the first heart sound is soft and pulmonary component of second heart sound is loud. In addition, there is also presence of a third heart sound. There is a presence of a pain systolic murmur at the mitral area, which becomes loudest during the expiration and radiates towards the axilla. In addition, there is also presence of a pain systolic murmur at the left lower sternal edge in tricuspid area, and it becomes louder during the inspiration. In lung fields, there is presence of the bilateral basal crepitations. There is no stigmata of the infective endocarditis. The diagnosis is severe mitral